Good afternoon and welcome everyone to our monthly Geri ECHO webinar. My name is Sarah Tompkison and I'm a social worker on the Geri ECHO team. Joining me on the team, other interdisciplinary team members are Dr. Lucas Morgan, Dr. Reese Ueno, pharmacist, Dr. Courtney Nunokawa, nurse practitioner, and Dr. Rita Bell Fernandez. I just wanted to acknowledge that our sponsorship for this CME activity is jointly provided by the Queens Medical Center and UH Jabsum Department of Geriatric Medicine. Just a little bit of housekeeping and evaluation forms. As a reminder, evaluations are required if you want to request for CMEs or social work CEUs. You can find the evaluations by following the link in the chat that will be provided after this webinar or at any time on our website and email advertisements. As I mentioned, we are not only offering continuing medical education for doctors, nurses, and APRNs and physicians assistants, but we also are providing certificates of attendance for CNAs and students, along with the NASW CEUs for social workers. Please take note that with regards to the CME, you will be sent the CME records by Queen's medical records in mid-January of 2025. So you won't get it after today. You'll have to wait till early next mid-January. We really do appreciate your comments, your suggestions. It's helpful for us in the planning as a committee for future programs. We again want to emphasize that this ECHO webinar, it serves as a forum for mutual teaching and learning from experts and from each other on the front lines. As the ECHO motto goes, all teach, all learn. And in the spirit of Aloha, we encourage you to please turn on your cameras to help us build this community of learning. Feel free to eat lunch because we want you to take care of your health, and good nutrition is an important healthy lifestyle. The format for our webinar this afternoon is a short lecture from our expert presenter, followed by open comments provided by the ECHO Hub team members I've introduced you to, and then you, the participants. We will welcome any questions, even case examples for discussion. Additionally, we invite you to share any other geriatric cases. And lastly, we ask that you please keep your case discussions HIPAA compliant. And this includes not sharing the patient's name, birth date, address, and so on. We learn best from our patients and our clients. They are our best teachers. So today I'm very delighted to be able to introduce to you today Dr. Aida Wen, who's going to be presenting on the topic, Doc, can we medicate their agitation? Just a little bit about Dr. Wen, since she's such a humble person. Did you know that in addition to being an associate professor with the Department of Geriatric Medicine with the John A. Burns School of Medicine, she's also oversees the Geriatric Medicine Fellowship Program as the director there, and she's also the principal investigator for the Geriatric Workforce Enhancement Program, which is abbreviated term is GWEP. She also serves as a medical director for Manoa Cottage, the Kaimuki Nursing Facility. She's a geriatrician with the Queens University Medical Group and also a consultant for Aloha Care Division of Long-Term Services and Supports. But this is an important piece of fun facts about Dr. Wen. She not only can speak Chinese, but she is a very accomplished violinist. And I've heard her play the violin, and she's an artist, drawing. And when she's not sleeping and working, she also does a lot of community volunteer work with her church, the Caregiver Foundation, and the State of Hawaii's Alzheimer's Task Force. Without further ado, I again have the pleasure of introducing Dr. Aida Wen. Thank you, Dr. Wen.
Thank you very much for your very generous introduction. Use my coughing. Okay, so let's see if we can share screen. Hold on, share screen. This one. Okay, you guys see that? Okay, great. Okay, so Doc, can we medicate their agitation? So I get this call all the time. There's no surprise. I mean, it's a very difficult problem, right? When you have dementia, sometimes we see a lot of behaviors, and it really is very difficult for caregivers. So they call us. So today, what are we going to talk about? We're going to talk about, well, first of all, describing dementia behaviors. You can't treat it properly without a good description. Recognizing and evaluating delirium, managing a behavior crisis, knowing when medication is appropriate, and being able to implement strategies to prevent dementia behaviors. So, Doc, my patient is agitated. What does agitated mean, right? Repetitive actions, wanting to go home, abusive, irritable, accusing you of cheating. You've seen all this, right? Accusing you of stealing, resistive to bathing, restlessness. They fight you on anything, right? Repetitive calling out that drives you crazy, aggressive, screaming, all of these things, right? So sometimes they're mild, sometimes they're severe, and they're all different, right? And so if we have so many different behaviors, should we treat them all the same way? Of course not, right? That's why we need to understand each one a little bit better. So if somebody calls me, Doc, I need something, give to, this patient, I don't just throw them some medicine right away. I have to find out more information, right? So we have to find out, well, how dangerous is it? What are we talking about, right? Tell me more about her agitation. We need some more descriptions. And can you tell me if you've tried anything else to get his or her cooperation, right? Then we can try to figure out what's the best thing to do. So we'll start with a case scenario. Oh, this is Mrs. S. She's an 80-year-old woman who had a fall 3 weeks ago. She went to the hospital where they found no fracture, just bruising on her left hip. The rest of her medical workup was fine, and she was started on an antidepressant 1 week ago because since her fall, she was just not motivated to do anything, basically stayed in bed to rest. In the last 2 days, she was sleepier during the day, but also more restless at night. She's not following directions, but she resisted personal care, kicking and hitting anyone who tries to change her wet undergarments or bedding. So what's the first step? Assess the situation. Are they a danger to themselves or to others? Right? So it's sometimes helpful to remember that, we all need to defend ourselves, right? We have an urgent need to feel safe. If we feel threatened, we're going to strike out, right? Or we're going to hide away to feel safer, right? So oftentimes this agitated behavior is an attempt at self-protection. And if it's dangerous, then, well, we need to remove the person or the items that present the danger and to control the danger sufficiently to allow time for watchful waiting or cooling off. Sometimes if you back off a little bit, they will tell you what's bothering them. They will scream about something or mutter about something or indicate what it is that's bothering them. So sometimes just remove whatever the danger is and sit back and see if they tell you what these things are. So if they're still dangerous and you can't, and it's not safe, by all means, call 911, right? But I also want to tell you that, yeah, we call 911, but you should also know that there are basically no geriatric psychiatric beds anywhere in Hawaii. So they're probably not going to admit them except for a medical workup. So they'll get labs and a urine and a chest x-ray or whatever it is. And then they'll send you back home with you, right? Or send them back to the nursing home or wherever it is. So, and besides, even if they hospitalize them, it probably not solve your problem because the hospitalize them, they're in a setting where they really can't be dangerous and they'll get sedated. And then once they come home, they'll be off those medications and voila, they're back to where you had them before. So ultimately, a change in approach is still the most effective intervention, right? So learning how to handle these behaviors until they are better is something we need to really think about. So if it's not dangerous, then like we said, we back off, right? We do tada, which is tolerate. If it's not dangerous, allow them to respond to the environment and observe them to get clues to what's upsetting them. Anticipate. So another thing that's a helpful way to think about behaviors is that it's a form of communication. They can't tell you exactly what it is they need, but they are communicating. They're trying to communicate in the best way they can. So try to think ahead and meet their needs and avoid frustration or danger. And then finally, don't agitate. So, like if you try reasoning with them, you're not going to get anywhere, right? So, um, even reorienting them can make them upset, right? Because, what do you know? You're wrong, right? So just go with their flow. Try distracting or humoring them. So just whatever it is, don't make the situation worse, right? They're not in their right mind right now. Don't make things worse. Just give them time to cool off. Then, as I said before, they're not feeling safe. So we need to create a safe environment. We need to create a safe approach. So oftentimes, instead of just walking right in on them, right? Let's back off a little bit, slow down. These are strategies taken from Positive Approach to Care, of which Sarah is a trainer. But this is a strategy for connecting in 3 ways. 1, visual, 2, verbal, and 3, touch. Right. So before you touch them, you got to do the visual connection and the verbal connection. So visual means something like coming from the front. They see you coming, you stop outside their personal space, 6 feet out, and you say hi and you wave so they can see your hand waving. Offer a handshake, stick your hand out, offer a handshake, see if they take it. Move slowly, right? Get to the side so you're not confronting them, and even get low. Sit down, kneel, get to their eye level or below. And then, yeah, say hi, whatever their preferred name is, and wait. Don't rush them. See how they react. Sometimes it's a little slow, and say something nice and friendly, like, "Wow, what a nice shirt you have. I love that color." Right? Introduce yourself, and then wait. Wait for some kind of connection before you move closer. And then finally, touch is the last. You might do a handshake, and then you do this hand under hand technique, which is a whole other presentation in itself um, that Sarah will do, that Sarah can do. Okay, and then this part of the safe approach is, now you're in front of them, you have to create safety, right? You have to think about, oh, my body language. Am I with my arms crossed? Have I open attitude? What is it like? Speaking slowly and calmly, show empathy and respect, and address their feelings, right? Apologize. That goes along with agree with them, right? Back off. If they're really, really upset, you know what? Back off and come back later. They might be a new person in 5 minutes. How else would you feel safe? If showing concern. I noticed that you didn't eat breakfast this morning. Are you okay? Can I do anything to help you feel more comfortable? Anything else I can do for you? just listen when they're speaking and nod your head and acknowledge them. Don't dismiss them, right? You have to do your best to create a safe space and just show that you care because feelings are very important. And this is very basic stuff, but it's very powerful and it goes a long way. What else? Part of the safe approach is instead of pushing your agenda on them, right, and doing stuff to them, you do stuff with them. So promote this partnership. Ask for permission. Ask them, help me out here, right? Give them a couple limited choices, right? Redirect them, right? Consider what are their favorite foods, favorite drinks, who's their favorite person. I can bring into this, right? What's their favorite music? And then show and do things together. So if an intervention is person-centered or strength-based, that honors the person. They feel like, oh yes, they know me. They know what I like. And there's cookies coming up. Cookies are my favorite thing, right? I have a reward after I do take the shower. I have a cookie, right? Do something that honors that individual in a very person-centered way. And then also take care of the whole person because there may be multiple needs. And again, right, basic relationship building. Very basic, but very powerful. And we just have to be more mindful of this. And so what are you going to tell the doctor? Just saying agitation is not enough, right? How would you describe it? So sometimes it's good to think about it. Is it, okay, what's going on verbally? Are they aggressive and screaming, cursing, verbally abusive, that kind of verbal? Or is it more like not aggressive, but maybe they're crying? Maybe they're just sobbing and weeping. Maybe they're just anxious, saying, help me, help me. Maybe they're irritable. Maybe they're repetitive because they don't remember, or maybe they're hallucinating, having psychosis, right? Those kinds of trying to put a category into their verbal output helps the doctors figure out what's the best strategy for managing it. Also physical, because not it's not just what they say, what they do, right? Some people don't talk, they just hit you, right? Or kick or bite or grab, right? And if it's really aggressive, I mean, the problem with aggressiveness is that it hurts, right? And that's dangerous, and it can be dangerous. And so sometimes this actually can raise the level of the need of addressing things a little bit more quickly, including even medications, especially if it's really hurting somebody, including themselves. And then, or is this behavior, this physical behavior, not aggressive? They're just restless, not sleeping, tapping, pacing, or they have inappropriate sexual behaviors or things like that, you know. So that's what we have to differentiate, you know. And like I said, this is particularly dangerous. And what else is helpful for the description, right? When give us a timeline here. Is this new or is this not new? Has this happened before, right? If it's new, then we need to rule out delirium, right? These are the delirium criteria, right? Is it acute onset within the last 24, 48 hours? Do they also have inattention, like they can't follow directions, they can't focus, they can't follow your conversation? Plus, they have either psychosis, which is hallucinations or delusions. They're sort of seeing or hearing things that aren't there, right? Believing things that are like paranoid, or sleep-wake problems, like they're sleeping in the daytime, awake at night, being restless, right? And if they have this combination of things that just happened in the last 24 to 40 hours, get medical attention right away because there's something medical going on that we need to address, right? And if it's not new and this is just, this has been going on for 3 months and it's just kind of getting worse, but it's really been happening, we need to like, how bad is it? So if we're going to do an intervention, in order to figure out if it works, is to find out, well, if it's happening less often, if it's happening and it's less severe and they're more redirectable or something like that, right? So describe the frequency. Is it several times an hour or is it less than once a week, right? Interventions approach will be different. And of course, detective work. That's the name of the game, right? You have to be a really good detective. You have to look for those unmet needs that they're unable to communicate and then look for situational triggers. So let's continue on with the case. So vital signs were all normal. No constipation. She answers questions with short phrases, responds slowly. She does not open her eyes. You notice some skin breakdown on her buttocks due to moisture because she's refusing to be changed, and she does not let you touch her left hip. So you're thinking, well, this happened in the last 24, 40 hours. Maybe there's delirium going on. It got some labs. And lo and behold, the sodium is low. And there she's dehydrated. But she doesn't have a urine infection, right? So this new behavior is due to low sodium dehydration and possibly from this new antidepressant that she took starting a week ago. So, that's great. So, but she's still having behaviors, right? It didn't help you very much. The doctor's happy, they treated her, right? So, um, should we treat this behavior now at this point? So, the main thing here is really we should just treat the underlying cause, right? So we replace the sodium, we push the fluids, we stop the antidepressant, we treat with the Tylenol, the acetaminophen, right? And still you're getting this thing. Okay, so what's wrong? So should we treat it? Can we medicate this agitation? Because they sent you home from the ER, right? After giving her fluids and stuff, and they didn't really, so she's still refusing things at home and not letting you change her. So, well, what's the problem with antipsychotics and sedatives, right? They're really to be used really as a last resort. If she's patient is very, very distressed or in danger of hurting themselves or others, then the medications can be considered for the short term, not long term. So what's wrong with these antipsychotic medications? So it can cause metabolic syndrome, which is stuff like diabetes, high blood pressure, high cholesterol, and weight gain. In fact, there's a black box warning on these medications that say it can increase the risk of heart attacks and stroke and death, right? So that's not something we really want to start relying on for the longer term. And then more so, right? So if this is a dementia behavior, this is going to be a long-term problem. But if you keep these people on these medications, you may run the risk of having these movement disorders or extrapyramidal side effects, where you see Parkinsonian-like symptoms, right? So they're going to be like Parkinson's disease. There's tremors, they're shuffling when they're walking, and very slow movements. Or you may see this akathisia, which is this restlessness, or dystonia, where you have this painful muscle contractions, like twisting of their neck and their arms and their legs, right? Or tardive dyskinesia, where you have this involuntary tongue twisting, blinking, squirming, twisting, things like that. So these movement disorders are really troublesome, and they may or may not be reversible. So that's not, we really don't want to go there. There's other medications often used for behaviors, like very commonly the benzodiazepines, like Ativan. But basically, yes, they're very good at sedating people. It's basically a tranquilizer, but the problem is it's very addictive and it increases your risk for falls a lot. So that's not optimal either. And these antipsychotics we just talked about. There's other things like antidepressants, like citalopram and escitalopram. And there's other things like mood stabilizers, which are anti-seizure medicines, which basically quiet down some of these firing off nerves, right? So there's these other problems. So we, I always say there's no free ride. There's always side effects. So what's the lead things with the least side effects, right? Non-drug strategies. Geriatricians are so into this non-drug strategies. And even if you do wind up needing to take a drug, you can minimize the dose and the dangers of these drugs by augmenting with this as the primary strategy. So how do we get her to cooperate? I put here Felix the cat. Maybe it's the older generation, but Felix the cat was a wonderful, wonderful cat, right? And he had a lot of things in his bag of tricks. And so all dementia caregivers I know, when they get really good at this, they have a huge bag of tricks. They tried everything. And so if you go to the Alzheimer's Association or one of those meetings, you'll hear all these caregivers have different things in their bag of tricks that you can borrow. I'll talk a little bit about this detective work. So, finding the unmet need. I like to think of it like, Maslow's hierarchy of needs, right? Kind of start at the bottom. You have physical needs like pain, hunger, thirst, being cold or hot, constipated, overtired, right? These are the things like when babies cry, you have to kind of go through this list, right? Because they can't tell you what it is, but they're really basic physical needs. You have to go through that first, right? And then you think about the environment, safety needs. Is it an overstimulating environment? Is there a lot of anxiety going on? We have to help them feel safe, whatever it is. Then the other need, after physical needs met and you're feeling safe, the need to be loved, right? Need for belonging, need for respect, right? Are they depressed or lonely, right? And then the fourth one is having a meaningful life. They're not just sitting there with nothing to do and they're bored out of their mind. And so they have to find something. They will come up with things in their brain that will make them anxious. So we have to do this detective work, right? So I like to use this is an approach used from the VA, the STAR VA ABC card. So I say use the ABCs to find the triggers. And what is A? It's the antecedent. What happened right before the behavior? Who's there? Who's around? What were they doing? Where are they? What time of the day is it? Why? What happened? What's the possible trigger going on here? Unless you pay attention, you won't notice that, oh, maybe there's some common feature going on. This happens every day in the afternoon. It doesn't happen at night or in the morning. What's going on that's different? That's being part of that behavior. What is that specific behavior that we talked about earlier? Those very specific descriptors, and then consequence. Well, after this behavior went down, right? They started hitting people. What was the result? Oh, then they got put on the side. What was the result? Did they get hurt? Did somebody else get hurt? And what would you do if this happens again? Because probably it's going to happen again. If you don't know what caused it, it's going to happen again. Because we need to know if this happens again, how are we going to respond to get a different result? So thinking about it in the ABCs. Then part of the detective work is plan with the 3 Ps: prepare, prevent, and be present. So prepare is have a favorite snack available if the distraction is needed. So, if they like peanut butter and jelly and you look in the fridge and there's none of that, then you're stuck, right? Or if they like cookies and you ate your last cookie yesterday and you didn't go shopping, well, then you're stuck, right? So you have to prepare. Prevent. If afternoon is a bad time, don't have the resident in the common area at this time, right? Plan another activity for them. Make sure that, 3 o'clock's running around. Let's have them be in their room and let's turn on the music, right? Be present, right? So once they get agitated and we're a little late to the game here, right? Then we need to be present with them, walk with them, acknowledge their frustration, and maybe lead them to a quiet area, lead them to another activity, be present and, hear them out and hear out their feelings, right? So because we don't want to trigger a whole cascade. And once the thing starts, right, you don't want it to keep going. We want to just kind of cut it off right there and then redirect to something else. So we're gonna go back now to Mrs. S, right? She had a fall, she had no fracture, she had bruising, negative workup, and now she's just kind of restless and sleepy. We figure it out and we're treating the underlying condition. So what was the source of this agitation? What is the unmet need? Any ideas? I can't see the chat box, so somebody will have to read it for me. If somebody says pain, yes, you get a thumbs up, right? Because she had a recent fracture 3 weeks ago, not that long ago, and she has bruising. Sometimes people don't think if you have no fracture, then you're set, right? But it's not. Bruising hurts. And so maybe we just need to pre-medicate her with Tylenol and just make it a standing dose twice a day and do that for like 2 weeks until it's a little bit better, right? So yeah, maybe that's the unmet need, right? What are, right? We have to think about these. What are the triggers? what was the trigger what was the behavior that she was doing, right? She was not letting people take care of her and hitting those who tried to change her wet garments or bedding, right? Is that the trigger here? Who was around? The caregiver trying to change them, right? And what was their behavior? They're physically hitting and striking out and pushing away, right? So what are some of the things that we can do to prepare to prevent these behaviors and to be present? So I'm going to ask for some people to type in the chat box and let me know what your ideas are for this approach to approach this lady.
Sarah, you had some ideas. Want to share those out loud?
Sure.
In the chat?
Yeah. So I think because we know there's a delirium, and unfortunately, deliriums can last for weeks, months. And we know now the cause probably is a combination of pain, because it was noted that there's this skin breakdown. I guess it was recorded, yeah, she has some initial skin breakdown, and she's sitting in her soiled or wet diapers. But I think I put in the approach, a couple approaches is family care partners really need a lot of emotional support, because oftentimes they're at a loss with this kind of new behavior, or not, they're feeling helpless, like, am I doing everything in my best ability to care for my parent? And they themselves are just not getting the rest they need. So I noted that another intervention might be looking at respite, and really just giving family caregivers permission to say, you're just doing an awesome job. You really are taking care of your mom since that recent fracture, and being willing to take her into your home and making sure that the therapy that she's receiving is at home. But would you consider maybe asking your family or to see if they could give you some extra time in the home so you get a break? If they have financial resources, and it's even looking at private duty home care services, only because sometimes there's long wait lists for the community agencies to get government type of bathing services or personal care. But I just kind of threw that in there. It's just, you just got to write it out. It really takes a lot of time for people who have delirium. It's just, oh yeah, Courtney has some other comments too.
I like the frameworks. I was thinking about it within the framework of prepare, prevent, be present. Um, and I think it's that prepare, and as Sarah was saying, it's like really like anticipating these things prior to, and then building out the time and resources so that when you have this triggering event, you're not rushing through it or trying to do it in a way that worked before but isn't working currently. Yeah.
And that thing about time, right? If I'm the person that's the family caregiver and I know that I have to pick up my grandson in the next 15 minutes because he's getting out of school and my boss just told me you got to get this report in before the end of the day and my mom's yelling the person's yelling like, come over, help me, somebody help me because she's in pain, maybe she's just in discomfort from the depends. I got to make sure that I've built in making sure that I put time aside. And if, like that's what you just mean by prepare, right? So that you can plan, and
And
yeah,
yeah, and it allows you to be present, right? Being
right.
present, being calm
Calm. Yeah,
and pleasant, not bossy, not losing your temper, right? Is that possible if
it is.
you haven't prepared?
Yeah. No, if you're not prepared,
Prepared,
if you,
it's
yeah,
not possible to be present, right? It's
right.
hard. And then being sweet and patient, encouraging, and you know, so it's hard. So preparing really helps that, help you be present
Yeah,
because once you change your approach, right, all the vibes rub through, right? They know you're sweet. Oh, then yes, then they react to that same energy.
yeah, yeah.
Then yeah.
Yeah,
And
I think, yeah, because people living with dementia, it doesn't matter what you say. Really, they don't care about how many words that are coming out of your mouth. They're really looking at your nonverbal um, behavior, in your
mhm,
eyes, your face, and if you're like looking irritated at them, they're gonna just feel as helpless and they're gonna feel just as irritable.
mhm.
So I think, yeah, we have to be aware, like you were saying, Courtney, to anticipate ahead of time be aware of where you're at, is what you're saying, Aida. Because
Yeah,
if I'm not in a good place and I'm rushing because I have to be somewhere, or I just had a fight with my husband, this is not going to go well.
that's right. It'll spiral out of control, right? Another part of being present is, instead of just going in and changing her as fast as you can, right? Let's go in slowly. Let's talk about it. Let's explain every step and make sure the towel is warm and it's comfortable and you can hold the towel, squeeze it. It feels okay, use the towel, just rub yourself. Yeah, you go ahead, you do that. And as they're rubbing themselves and you can change the diaper, you know just slow it down and check every step. Is everything okay? You're doing a great job, I'm doing a great job, and we can get through this. Not rushing through it, but being present, doing it together slowly. So that's part of being present. So then you can change the outcome and nobody's going to get hurt, smacked or kicked, right? Or punched or bit. Okay. And then prevent, right? How do we prevent this from happening? Right. Maybe,
Timing.
yeah.
Your timing, their timing, might not be good time for them too. Maybe something else is bothering them. Maybe they're hungry, but they can't tell you.
Right. Yeah.
Courtney mentioned, like you said earlier, also pre-medicate with pain medicine of some kind.
Right. Right. Before we start moving them around, if her hip hurts and you're lifting up her bottom to change the thing, wow, you are going to trigger some major pain there. Right? No, make sure she's got the Tylenol on board. If you have to wait an hour for the medicine to kick in, and then go ahead and change her. Right. So those are great. All right. Thanks, guys. We have Oh, another case scenario I'm going to let you guys come up with. So Mark is a very active 78-year-old man with dementia who wheels up and down the hall, and he goes into other rooms rummaging, reaches across the table and takes things from everyone, including food, and he hoards napkins and forks and everything. And this behavior worsens in the mid-morning and the late afternoon. This has caused a lot of yelling and fighting in the house. Anybody see this before? This kind of behaviors? I see some nodding heads. Good. All right, so we're going to do this. I want you guys to ask yourselves these questions. Is there an unmet need? And what are the ABCs? And prepare, prevent, be present. So what do we think? Because we know this is going to happen tomorrow. This happened yesterday. It happened last week. Right? So what is the unmet need? If we look at that hierarchy.
One question from Veronica that's speaking to this is he bored? So is there an unmet need for possibly engagement
Mm-hmm.
in something?
Mm-hmm. Yeah. Why do we say that? Why do we think he's bored? I think I look at
like,
the timing.
and he's literally going into rooms, like looking for things, almost like he's seeking something out and hoarding things, taking things. So these sort of agitation behaviors are sort of active and seeking or procuring, you know.
Mm-hmm. Yeah.
We
And
also have some, oh, sorry, go ahead.
Yeah. I noticed that it's mid-morning. Usually morning is everybody's got this routine, right? You get up, you get in the bathroom, you do your morning things, and you have breakfast. And what happens after breakfast? There's a lot of hours in between breakfast and lunch, right? Got to find something to do.
Those sort of doldrum periods between activities, which are often meals in a lot of folks' lives. So folks also have mentioned maybe hunger, you know, maybe there's sort of like a hunger between meals that's being, you know, activating these behaviors.
Yes.
Curiosity and even toileting needs. And also looking for food he wants and maybe not liking what he's getting during meals is another common.
Yeah, right. I have patients on pureed diets that want to eat somebody's cake. Right. Okay, so what are we going to do now? This is going to happen again. What are we going to prepare to prevent? And if this happens, next time he's grabbing somebody else's stuff, what are you going to do? How are you going to be prepared?
Could you have something with you in your pocket that you could give him as an alternative thing? Maybe something that maybe you know that he's been interested in the past, and oh, here's your thing. Put it in your pocket. Prepare.
Especially if it's a patient-centered thing, right? You know that they love sports or whatever it is, and you happen to have a magazine right in your pocket about sports. There you go, right? Do you have to wait till he's doing it? Why don't you just set him up after breakfast and say, hey, we got some sports going on. Actually, we found the channel on the TV, right? Or the magazine. Right? So we're preventing and also being prepared in case this happens when we don't expect it.
and people are coming up with different ideas about sort of layers of preparation. So, like you're saying, what happened? What about preparation for when it happens in the moment? How do you react with what's in your pocket? Maybe. But some other ideas are about bigger scale preparation as far as having him involved in tasks like bingo or TV shows, and just having things prepared for these times of day to proactively engage him in, that help
Yeah,
him connect.
right. Any other great ideas?
Anyone want to add verbally what they've written in the chat so far? Renata says change the scene. Could have food or other activities outside, kind of add some variety to the environment.
Or change the caregiver. So they preferences, some guys like only male caregivers or only female caregivers, right? Or whatever it is, right? Yeah. So as you can see, right, if that means we just go into this more prepared, right? And ready. So we don't need to medicate. It turns out that, there are really difficult behaviors, really resistant, really tough ones, but I would say there's not over 95% can be managed by a change of approach, a change in strategy. And these are the strategies that we need to teach. So oftentimes, if I get called from a nursing home or whatever with patient behavior and they're asking me for med, I actually I make them try different things before I give them anything. Have you tried this? Have you tried that? Have you thought about this? Have you thought about, okay, go try it and then call me back. Then they go and they call me back. Hey, doc, it worked. Okay, great. We don't need to do the medication, right? So we have to teach the caregivers this whole approach. Okay, so I just threw in another in case, I was prepared in case people didn't have cases. Case number 3, right? So Ron moved in 1 week ago. He has been restless every afternoon and evening trying to leave the house. When you tell him this is his new home, his wife has died, and his house is sold, he gets mad at you and he screams, "You know nothing." He's refusing food, drink, and meds. He says, "I am not a prisoner. I don't belong here. I'm calling the police." And he pulled the door so hard he broke the doorknob. Anybody seen anything like this? So, should we just give him some Ativan? No. Right? What should we do? What's his unmet need? Let's think about that Maslow's triangle. What's his unmet need?
One idea is loneliness, or maybe his unmet need is for connection, and so loneliness is kind of a result. Or another idea is there's maybe feeling depressed and lonely and about his wife passing, so there's maybe grief, missing home, and then safety, security, another idea. So
okay, so we have to do something. We have to do something to help him feel like he belongs. What are we going to do? Any ideas? I mean, he knows this is not his house.
Yeah. And so Sarah mentioned there may be fear about the new environment, different caregivers. So how do we help him feel more comfortable and less afraid? Courtney's idea is bring things from or that remind him of his home, pictures of his wife, family, things. Veronica says maybe bring things from his home that he might recognize or schedule visits with familiar folks, family or friends. Modify the home, that's one idea to enhance this feeling. And another idea was maybe visit his wife at the cemetery, if that's possible, or take a walk.
Yeah, all good ideas. And then, maybe he just brought him in, dropped him off, and he didn't even get a tour of the place. He really has no context, right? This is the new place you'll be staying at. This is, where you'll be living. Actually, I know this is, I don't know if this is a good thing. I had a nursing home resident who was very happy to come to the nursing home because he was told that this was a cruise ship.
Yay!
And there were all these activities and all these people. And this was his room on the cruise ship. And he was fine. But yeah, somehow he's got to be oriented to the place and have things familiar from home. And then maybe trying to make a special connection, right? Becoming his best friend in a way. He has to find a friend. Gotta be actively. You think these guys can find friends easily? Maybe you need to pair them up, right? Make an effort.
I was just going to add to Aida. Oftentimes we forget that, there's still this personhood. And, some of the things Lucas mentioned about being lonely and sad and depressed or even grief. So I think just to validate how he's feeling, I mean, like, this must be really hard for you. I'm sorry. Meeting all these people is scary, but I'm here. I'm here to help you for the day. I'm your nurse or nurses or whatever. And I wonder if you want to join us for the ice cream social they're having outside. And then you do the little distraction. But I think sometimes you just forget to validate what people are feeling.
So he doesn't feel as lonely, right? Misunderstood. Yeah. Yeah. And then, if this kind of stuff that we just talked about is shared with the entire care plan and everybody's on board, imagine that. Then everybody will make their small little interventions. Yeah. And then of course I'll just open up to any other situations that you found challenging that you would be curious to get some input from everybody here. Anybody got some winner cases?
There's so many. I can't think of like one specific thing right now. There's so many patterns that you mentioned in the cases that are familiar and feel very familiar. I think something that I really like, just kind of reflecting on the presentation and looking at behaviors, is really like a stress response. I really like this approach because it honors the caregivers and the nursing staff and the healthcare provider, to give them like that tolerance and spaciousness that you need to talk, because it's really hard for the family members when there's people have internal beliefs about my father's not eating, and then that causes a lot of distress for the caregiver, and so they want them to eat because of their own belief systems. And so building that tolerance to understand you're not harming them or you're not hurting them, and there's there's the guilt and shame associated with them not eating for the caregiver itself. So I like that tolerance piece a lot, and working with your staff and caregivers.
Yeah, I think so much of this, it just strikes me as so much of this depends on the people who are in the caregiver roles in their environment, in their life day to day, and how to, right. I think, Courtney, you're speaking to this, and, how to get folks to prepare in their ways of like learning a new way of thinking, and seeing this from a whole new perspective when there's so many things from their past, or that lead to unhelpful ways of interacting. So, and the more resources we have, like the positive approach, those types of trainings, and the more things we have, like, hey, here's a thing, this will be really worthwhile and helpful. I think those are always helpful. And
I think it's just being
Veronica,
creative, right, Lucas? You got to be creative. I think, like, for Courtney and you and I, when I worked in adult day health care, everybody wants to go home, and everybody wants to go home at the same time. And so I mean, like you have 50 people and five, and then they feed off each other, right? It's like, well, and they see the daughters coming earlier. So it used to be really hilarious. But I was going to say, in applying some of what Aida talked about, we had one woman, we had to be creative because she felt like, well, the need was she smoked. She was a smoker. So family didn't tell us, had they told us, that what they do to bribe her to come to daycare is they let her smoke a cigarette before, and after she gets home. So, well, we can't have cigarettes. So guess what we did? You remember those candy cigarettes? I know this sounds terrible. So yeah, so someone brought some kind of, well, we started first with the gum, but the gum wasn't going to cut it out, for she needed to have that cigarette. So then we started to roll paper because at least she had something to hold. And then we found those little candy cigarette, those things. And she was so happy. I think it said, what is it? Not Marlboro, but it has some on it. But she was happy, and then less restless, because she would get less, very restless and irritated with everybody at a certain time. And that is because of the. And I told the daughter, next time, I don't know, put some kind of patch on her. But yeah, it's
prevent in some other way. Right.
Great story.
Just wanted to orient folks. There's a link that John put up there for the evaluation for CE credits. And Veronica also asked a question. We don't have a ton of time right now, a few minutes. What are your go-to medications that you use if non-medication options do not work?
Dr. Wen, I guess, like, I'm on call for the adult geriatric Hawaii Pacific Health Group, and we'll always get a call in the middle of the night. This patient's agitated, hitting, the whole bit, and, we'll try the reorientation, and, we don't want to send them out if we don't have to, because we know that's not going to, do anything, because we can do labs and x-rays at the facility. But sometimes we'll use Lexapro, or sometimes we'll use like trazodone instead of Ativan. But I was just wondering, what are your go-to meds?
Yeah, so this is a whole other talk, but this is why we need a good description. Because if they are on this agitatum, are they on the depression spectrum, the psychosis spectrum, the anxiety, or is it the circadian rhythm is all wrong? Depending on all those features, we select, right? So, yeah. If it's happening at night, trazodone's good, If it's happening during the day, Lexapro may be good. Not always. Sometimes it's sedating. So it'll depend. A lot of behaviors actually are are kind of like underlying depression. So sometimes an antidepressant is just as efficacious as an antipsychotic. If they are particularly violent, then, or labile, then maybe one of those anti-seizure medicines, right? So, or prazosin, or if it's more like PTSD. So that's when you get in touch with the Geri Psych person and really nuance all of those decisions, because there are many choices. All of them have side effects. You got to depend on what their profile is and the side effect profile. So you balance it between their profile and the side effect profile.
Sounds good. The reason I ask is because our Geri Psych, usually it's like 3 months out.
Yeah. That's the problem, right? We don't have access to a Geri Psych unit. We don't have access to Geri Psych. We just kind of, and we want to minimize all of these medicines anyway. And so the more we can really study these behaviors, then and get at them faster, find the solutions faster, then we can minimize the doses of the medicines or the need for it. So
very important and very complex, and maybe we could have a whole nother talk on this sometime soon. That'd be great.
Stacy has a question, I think, Lucas.
Yeah.
Okay.
Hi, Stacy from Malu here, Adult Day Health.
yes.
And just a question. Recently we've had a bunch of participants come to our center from other centers, and they were given or told to use melatonin to address behavior, like kind of to take the edge off during the day to help with some of the behaviors. So I was wondering if you heard of that strategy and what are your thoughts on that?
People do use that strategy. That's not something I like to use during the daytime. What is melatonin, right? It's a good it tries to reset your circadian rhythm. So are you trying to set their circadian rhythm to be sleeping at night? I mean, during the day, or mess up their nighttime sleep or something? I don't know. I have trouble with that. So I'd like to think about what's the underlying problem. It's not really sleep. But I get there are people who use that.
They should, I'm guessing they should check with their doctor first, though, if they decide to use it. Yeah.
I think people are Googling a lot and looking, like they Google and they look up some kind of help. They look on medical, not medical journals. They just kind of, maybe Stacy and melatonin.
Somebody family says, I don't know. I was just curious what if anybody else heard
just getting to the melatonin thing, sometimes, well, I'm more irritable if I don't get enough sleep at night, right? So if they're not really sleeping well at night and they're restless all night, then maybe a melatonin at night is a very good thing, and then they sort of reset and then they're good in the daytime and they're less irritable. So I've done that too for patients.
Yeah, I guess the center is using it. They're using it in the daytime and nighttime. So, and they swear good results. So I don't know. I was just curious. Thank you.
I don't know. I just don't think sleepiness is a really good quality of life.
Well, thank you, Dr. Wen, and thank you to all our attendees. We had such a beautiful session and we learned so much. We learned tada, we learned star ABCs. You took us back to kindergarten. I love it. Thank you for all the beautiful clinical pearls and the case discussions. We will end this afternoon. A warm aloha to everybody. Thank you, Dr. Wen, for such an amazing presentation. Bye now.
Bye.